and a privilege to be here. I feel very much the same as Dr. Gadre when I say, at no time in my life did I imagine that I would be here at Ames having this conference and having this conversation. Though I must say, for at least 10 to 20 years I've been waiting for this conference. How many here are clinicians? Please raise your hand, those who you see patients. Many. That's good. How many of you remember when you first made a decision to go into healthcare, go into medicine? How many can remember that? I also can remember that. And for me, this is a moment of great sort of heartfelt emotion because my father wanted me to go into medicine and I refused. And I remember saying to him when I was 14 that I was not going to become another technocrat. I was 14. I took some time away from college. I was studying philosophy there. And I took a year and I traveled and I came to India and I visited family in Punjab. But I also went by train throughout the subcontinent. I spent 3 months just traveling around India. And that was when I first made the decision to go into medicine. And the reason was really, I had been politically active. I had been involved in the anti-war movement in the US. In that moment, it was the sea of humanity and the ocean of need in the country that moved me and made me realize that whatever you do in politics or activism, when you're face to face with one other human being, you are doing some good. And that was the decision I made. And I made that decision while in India at the age of 20. So to be here to discuss these matters is very important and meaningful to me. Let me tell you a little bit about my journey because I was able to train with Dr. Lown at Harvard. I then started a medical device company. So I have participated in the capitalist system. And then I was in private practice for many years, but I returned. And how did I find myself on the streets of Boston doing this work? This is a man I met on the street. We were doing a project where we asked people to come tell us what worries them about their health care. And he wrote here, when I realized that my doctor cared, that made me care about myself. It's all about communication. So this was part of Right Care Action Week, and we did more of that. And we got some press. This was in the Boston Globe, but it traveled all over the US. We were doing this work. Now, this was not a scientific study. This was not meant to be definitive. This was more a demonstration. You could call it a publicity stunt, but it was what it was. And we did that because of a long journey that I took. Before I came to see Dr. Lown, I was at Johns Hopkins, and I was an intern, and I was in the coronary care unit. And I was there by myself overnight. We prided ourselves on, being the tough military guys, and we would do this work. And a man came in with a massive anterior myocardial infarction, and he had heart failure, Killip 3 heart failure. And I took care of him, listened to his lungs, managed him medically. And I actually was so concerned because he was obviously high risk. I had the nurse bring a bed next to the patient, and I slept there, and she would wake me up every hour. I would listen. We would treat him, and all through the night. And the next morning, we did rounds with my professor, and I was very proud. I mean, because the goal is you get through the night, and he's still alive. That's victory. But my professor looked at me and said, "What did you do?" I said, "What?" "You did not put in a pulmonary artery catheter." This is a man with heart failure, massive MI, and wears the Swan-Ganz catheter. This was 1981. The Swan-Ganz had been invented in 1967 or 68, and for 12 years it had essentially become standard of care in coronary care units. And in that moment, I felt ashamed. I felt I had been lazy. I felt that I didn't know the science. What I knew was I knew how to take care of this guy, and his pressure was fine. He was maintaining pressure, and he had heart failure. How complicated is that? The reason I tell this story is because 3 years later, a randomized trial was done. And that's the two arms of the trial, one on top of the other. There is no difference. No difference. And I think it illustrates a real problem we have in medicine. So today, what I want to do is share with you my perspective, share a framework. I do feel very humble with all of you here because there's a lot of expertise in this room, more than I have. But I will share some of my framework, and perhaps it'll be helpful as we spend the next day and a half, 2 days, tackling what are obviously very difficult problems. My central thesis is that, there is a paradigm in modern medicine, and there are many components to it, and it has run its course. And I believe we're at the end of a historical cycle, that there is a crisis. And in order for the crisis to be resolved, we will actually need to invent a new mode, a new paradigm. And as complicated and difficult as that may be, I see no choice. But as others have said, I also believe the third thesis is that such changes can occur. They do occur. And part of the glory of being a human being is that we can anticipate, plan, and intentionally make change. And that's why we're all here today. Now, in the United States, I will not pretend to be an expert of Indian medicine, but in the United States, we have a real problem. Costs are rising. People are getting bankrupt. They're becoming poor. The quality of care is declining. There's increasing corruption. There's economic taxation. There's social inequality. And all of these things are happening in a way that includes trillions of dollars of waste. Perhaps that's familiar to you in India, I don't know. But we have many of these things, but really my view is they're symptoms. They're not the disease, they're the symptoms. And an Italian once said, the crisis consists precisely in the fact that the old is dying and the new cannot be born. In this interregnum, a great variety of morbid symptoms appear. Part of my view is I think we're in that period. Now, Dr. Galeria talked a little bit about some of the aspects of investigative medicine, and we've done some work on that, and there's a series of papers we published in Lancet that goes deeply into these questions. But fundamentally, what we know is that amongst the many things we do in medicine, the evidence is varied. Some on the right you see is quite clear. When you have a bacterial infection, antibiotics are effective. If you've had an MI, beta blockers are useful. But just to illustrate how difficult this is, we put antenatal corticosteroids in this slide, and after the paper was published, a study came out showing that, in fact, that's wrong. They don't work. But we also have things that are clearly not useful, and there are plenty of evidence to show that, yet still they continue. Arthroscopic knee surgery would be one, vertebroplasty is another. Elective induction of labor is a third. But as Dr. Galeria said, most of what we do is in the gray zone, difficult area where there's judgment, where the science is not clear. So in our work, we generated a list. This is from the Lancet series. We generated a long list of things that really don't need to be done. And of course, Choosing Wisely in the US came up around the same time we were doing this work. They came up with a list of, it's now I think up to 500 items. And there are other lists. There's a group in Washington that's compiled all the lists. It now comes to about 2,500 items that really have no value and should not be done. At some point you have to ask, can we really imagine keeping track of these 2,500 things? Do we need a computer? How do we do this? I think the problem is systemic, so we have to think more systemically. So I'm just going to walk through this very quickly. The problem is, where do we start? And in general, if we're clinically focused, we start with the patient. And we believe that the doctor and the patient have to come together and make a decision. But any clinician knows that there are many variables at play there. Science is part of it, but science is also increasingly, my view is, it has become a fetish. And it is actually not as scientific as the people who push it even believe. But that's a long conversation. I majored in philosophy, so I'm happy to have that conversation. But we know that trust matters. We know that fear plays a role on both the doctor and the patient side. And on the doctor side, the fear is not just the fear of, a lawsuit, which is what everyone in the United States says, oh, this is about lawsuits. No, I am a clinician. I know the fear is of making a terrible mistake. The fear is of doing harm inadvertently. It's a honorable fear, really. But out of that, sometimes decision-making can be flawed. And so the drivers of care are a very complex ecosystem. And of course, families, culture, various forms of intellectual bias, and of course the culture, the contracting, the power relationships between different groups, including different specialties and primary care and doctors and nurses. All of that plays into how decisions are made. And as we start thinking about it, we recognize that there are all these global forces, mass media, and of course, the corporates, the medical industrial complex. They're all playing a role. And even when we believe we're alone with the patient in the room, that decision is being influenced by all of this. So it's a very difficult challenge. But in order to clarify, I believe there are three main vectors in this complex system. And one is knowledge. Power is actually more important than we realize. And doctors don't think about it as much and don't talk about it as much. And of course, money. And of course, we don't always talk about money except on coffee or in the evening or whenever. But it's always in the back of the mind. So let's start talking a little bit about knowledge. Now, modern medicine in America, the scientific revolution in medicine began about 100 years ago. A chap named Abraham Flexner was commissioned. He wrote a report. He said American medicine needs to become more scientific. The Germans know how, the British know how, let's be scientific. And so the scientific method was applied. And I don't mean to mock it, because it's actually very important that we have evidence, that we test reality, that we understand what we're doing. But in the course of the 20th century, this process has been corrupted a little bit. The great American sociologist of medicine, Paul Starr, in a book that, if you are interested, is well worth reading, because if you read it, you will see one possible future for India, perhaps not the future you want. And in the opening line is, "The dream of reason did not take power into account." That's the opening line. William Osler was at Johns Hopkins, where I trained. He was a Canadian, like I am. And he became famous for pushing the idea of science and the clinical pathologic correlation. And that became the mainstay of how we think about science. And so, of course, if you do a clinical pathological correlation on somebody who came 16 hours on a jet plane and did not move and suddenly is here giving you a lecture and just suddenly goes and starts to fall, it does not take much to think maybe that's a pulmonary embolus. And a big saddle pulmonary embolus, is what that looks like. But the real issue is that we now have technology that lets us see even smaller and smaller bits of emboli. And we have to start asking ourselves, is it the same disease? Is it the same condition? Does it have the same implications? And I believe the answer is no, it does not. And yet many people treat it as if it's the same, and so you get a lot of excess, unnecessary treatment, excess harm. And one way of thinking about this that I'll share with you is this idea that, we have a gradient of low risk to high risk and outcomes on the y-axis. And any given treatment or condition, has an effect that if you're at the very high risk end on the right-hand side, the harm of the treatment, which is a sort of fixed amount, that harm of the treatment can be overwhelmed by the benefit. So in high-risk patients, that ratio is favorable. But in very, very low-risk patients, the harm often outweighs the benefit. And so the idea of trying to apply, medical treatments on lower and lower risk patients creates some of these problems. And of course, if there's a force driving that thinking, then you can make errors. And so our friend or co-author of the Lancet papers, Paul Glasziou, just published this week the new hypertension guidelines and did an analysis and found that if you apply those guidelines in America, an additional 10, 20 million people will be labeled with hypertension. But 80% of those will get no benefit from treatment. 11% will get marginal, and only 9% will get some benefit. So the question is, what's the rate of harms? Nobody knows. And the problem is our specialty societies, professional societies, don't really think in those terms. And so they promulgate these guidelines, and they tend to always expand indications. And there are many reasons for that. But they expand indications, and they don't actually reduce them. To me, as a philosopher, this is actually part of a bigger problem, which I would call the idea of reductionism. We are now trying to turn the human being into small little bits of things. And each little thing, can have its own test. And each little, as Dr. Lown likes to say, the human body, there's an infinite capacity to create commodities out of the human body. Every molecule can have its own business plan, And that's a real problem of how we're thinking. And so the pulmonary embolism case, on the left hand it's a CT, and that's a saddle pulmonary embolism. On the right, it's a trivial thing. And of course, if you look at the literature of the last 10 to 20 years, what you see is that the case fatality rate for pulmonary embolism has gone down. The absolute numbers of deaths from pulmonary embolism has not changed, but the diagnosis has increased immensely. So the question is, what is the point of that diagnosis? It's these kinds of problems of scientific knowledge that lead to a deeper problem. And a colleague of ours, Vinay Prasad, published a very important paper. He looked at the New England Journal of Medicine, and he looked over a decade at major clinical trials that examined current practice. And 40% of the time, the current practice was completely overturned. What was like the pulmonary artery catheter I showed you earlier. This tells us that our knowledge base is still unstable, and maybe our framework is inadequate. So we need new science, and that's an important dimension of the work, though that's not, I think, the work today of this conference. It's important for us to remember that. And the quote I love from Albert Einstein, which I had never heard before, is this: nature shows us only the tail of the lion. We're only seeing a little bit of what we know. And so it's important to be humble about that. So money. What can I say? First of all, it's universal. Money drives hospital behavior, it drives patients' behavior, it drives clinicians' behavior, it drives commercial interests. We all know that. How you pay doctors drives their behavior. If patients have co-pays and an insurance, that drives their behavior. This is normal humanity. I don't think we should, by it itself, believe that that is a problem. But the problem comes when what we have is a systemic tendency in one direction. And really, I think modern medicine in the US, it sounds like also in India, the drive for profit is really paramount to the drive for health. And this is now becoming a really problem of crisis proportions. So the question is, how can we frame this so that money can help? And to me, the answer is, it's about how you invest. What is the infrastructure? How you structure payments? How much do you value primary care? How much do you value community-based care? That shows in the investments the healthcare system makes, that the society makes. And that is fundamentally how we have to think about money, as a way of achieving the system we want. Now, the United States, of course, is famous. This is a chart of life expectancy on the y-axis and total expenditure. And you see a kind of linear correlation. The more countries spend, the more life expectancy in general seems to grow. Now, of course, this may not be cause and effect. Many things are changing in these countries as they develop. The water gets cleaner, job security is better, etc. But the US is, of course, an enormous outlier. There's the United States, way over there. So the United States is really not a model to mimic. It's not a model to ape for any country that really wants an efficient, equitable healthcare system. And so let's talk about power. Power is many things. It's actually in the exam room, one-on-one. Sir, you have 3-vessel coronary disease, you have this, you have that, you need bypass surgery. Okay, doctor, whatever you say. There's information, there's a kind of difference of roles, there's all sorts of things that drive that. But the question is, how do you figure out what's the right decision? And I just want to leave you with one interesting fact. So in Dartmouth University, they do maps of the United States of rates of bypass surgery for every hospital region. And they plot those, and they show a real difference in different hospitals of the rates of bypass surgery. And when they plot them, it looks like this. Every red dot is a hospital region in the US, and the rate is on the y-axis. And they did a study in Canada, which has, a universal health system, and they found that the blue dot represented the Canadian rate. And so many people would say, oh my God, those Canadians, they're rationing, they don't get any medical care. And of course, the propaganda in the US is that they all come to the US for their bypass surgery. That's actually not true. But a study was done where a randomized trial was done in which patients were given time and full information about all the risks and the benefits of the surgery and given a choice. And in the randomized trial, after that, the Canadians, their rate went from this number to that number. It went down. So our idea of what represents the right decision really has to be thought about carefully. And that brings me to another important dimension that I won't spend too much time on, but it relates to our profession and our role. Our role as healers is an ancient role. probably we are biologically wired to have some degree of interaction, and the healing process probably involves some degree of social interaction. And we know this from the power of placebo. We know that, in fact, now there's imaging studies of the brain showing the placebo response activates certain specific circuits. So, thank you. So we are definitely in a place where we have to take that into account. And how powerful that is shown by the recent Orbita trial. This was a trial in which patients were taken to the cath lab and had a coronary angiogram. They were shown to have at least tight single vessel stenosis. Then they were randomized, and half them, the stent was put in, the artery was opened, and the other half, they were left on the table and nothing was done. And when they left, everybody else was blinded to what happened. And 6 weeks later, on treadmill testing time, there was not a significant difference in the two. Now, since the study was published, there's been a lot of controversy, but I will tell you, if you had asked someone before the study was published, what do you think? Almost everybody, myself included, would have said, oh, of course, if you open the artery, at least their angina will get better. So I actually don't know exactly the full implications of that trial, but it's important to recognize. And that's important to understand because this is not about artificial intelligence and computers. They're not going to solve our problems. They're not going to answer these questions. And most people do not want a robot for their doctor. Even a handsome robot like this from the movie The Terminator. You know, they want a guide. They want somebody like Harry Potter's Dumbledore. Or, you know, Obi-Wan Kenobi from Star Wars. Or maybe a woman who is a shaman of the modern world. They want a healer. That's what they want. So that's the challenge for all of us now. As we think about the money and the science and how we think about the power relationships, we have to take that into account and answer this old question. What is to be done? Now, I showed you the graph about the United States healthcare spending, and I showed you a snapshot, one moment in time. This is actually an important graph because now I'm going to show you the same data, except it's now going to be over time. Every country will now be over time, and this is what it looks like. So the red is, of course, the United States, and this is U.S. healthcare performance in the neoliberal era. On the y-axis is life expectancy. On the x-axis is health expenditures. And you see, as I showed you before, that contemporarily, the U.S. is a huge outlier. It's crazy how much we spend. But that's not the point of this slide. The reason I'm showing you this slide, oops, what happened? Oh, I see. I have to be careful. Thank you. The reason I'm showing you this slide is if you go back in time, the U.S. was not an outlier. The U.S. was with the pack. And if you blow that up a little bit more, you see what happened. 1975, it's in the pack. 1980, not quite. By 85, it's leaving. And by now, the healthcare system has been hijacked. How did that happen? My point is, there was no change in the population DNA. There was no change in the air. There was no change in the water. What changed? What changed was what the German philosophers call the zeitgeist. What changed is the spirit of the time, the feeling of how things should happen. And I will say, in the U.S., there was a very organized campaign to make that change. And that's a different conversation. But it was present in the popular culture. It was present in policy. I can point to laws that were passed in the 70s and 80s that affected American health care. But it was also in movies like Wall Street, where, we said that greed is good.
The point is, ladies and gentlemen, that greed, for lack of a better word, is good. Greed is right. Greed works. Greed clarifies, cuts through, and captures the essence of the evolutionary spirit. Greed in all of its forms. Greed for life, for money, for love, knowledge, has marked the upward surge of mankind, and greed, you mark my words, will not only save Teldar paper, but that other malfunctioning corporation called the USA. Thank you very much.
So that movie was part of the spirit of the times. And so I don't think it's a mystery. We have seen the results of a social experiment, and I just showed you those results. There they are. That's the result of a social experiment. That's not an experiment India should conduct again. Because who anyone is revealed in countries all over the world by the system of health care. And more importantly, the strength of a nation is the strength of their health care. So that's where we have to go. So I'm going to be talking later about the right care movement, but simply to tell you that we can join hands, we can work together, because the kind of care we want is a human right, it's not a commodity. But it will require serious effort and a radical transformation of the system. So we believe we can imagine such a future, and the task in this room is to begin to imagine such a future together, because we can actually do things together that's very powerful. This is a picture of an actual event. A child was drowning, there was no lifeguard, and people just linked hands and saved that child. This happened about 2 years ago in the US. And that's what we think we need. We need an alliance like that, and that's what we're doing in the US. We have chapters, we're doing writing in the newspapers. This was at Harvard Medical School. We had a protest march on the price of insulin. This was in Washington, D.C. And all of it is about restoring something important about who we are as a species. Because we are a species that cares. That's who we are. And I think that's how we have to think about our work. Thank you.